Ευχαριστώ πολύ, Άρη. Ευχαριστώ πολύ, Χρήστο. Well, I speak in English now. By the end, a bit of Greek. Well, we all know that we are facing difficult times. Two-thirds of Americans get their information from social media, and almost 60% of them don't believe that they are reliable. One of the last covers of The Economist magazine shows this question: the next recession, how bad will it be? That was just in October. Income inequalities are increasing everywhere to a dramatic stage. People face disenchantment and sometimes even rebellion, revolt. And all of this comes with increased degree of complexity. Now, a complex system is one which elements interact intensely among each other, and therefore they cannot be understood, addressed, or changed one by one independently of each other. Now, since complexity is increasing, it's also increasing our inability to understand health systems. And I think we'll agree that without a common understanding, it's difficult for us to converge in productive action and desirable change. Therefore, the issue is, can we do that? Can we share understanding according in relation to complex systems in a way that can produce productive action and desirable change? Can we do that? Well, I would say that I believe we can, and I will start doing that. The main issue of this lecture is trying to answer that question. Can we do this? And we start usually where the main problems of our population health are. And I think we can agree quickly the main challenge that our health system have today is not a disease, is not even a chronic disease, is what we call multimorbidity, which is, as the definition shows, multimorbidity is not about only classical diseases. It's about disease, it's about pain, it's about mobility, it's about suffering, it's about depression. All these that affect our quality of life are part of this challenge of multimorbidity. Well, the more interesting epidemiology study about multimorbidity shows that the prevalence that was done in Scotland is around 1/4 of the population, is bigger in places like Portugal and Greece, and also multimorbidity starts 10 to 15 years earlier in places with low socioeconomic level, in places where people live in deprived areas as compared to more upper class areas, and multimorbidity is heavily burdened by mental health problems, from anxiety to depression and other mental health conditions. Now, the conclusion of the study is that the finding challenge the single disease framework that which most medical practice, research, and teaching is based on. Now, in summary, this means, simplifying a lot, that we come from an era that we consider one condition that applies to everybody, one condition, one solution that applies to everybody, to a different area where we have a bundle of interventions and actions that apply to a selective typology of people. And if it's so, what's important is not classifying diseases, is classifying people. So now we need to know which combinations of actions can optimally work, respond to the kind of typologies of disease, of health that we can identify. Now, this cannot be addressed by this sort of system, that you have silos vertically that do not interact with each other. In order to do that, you have to go beyond that, and we have to find a way to manage one's path across different services. And this is what is here shown. This is the Dutch version of the Silos disease that our systems suffer from. And the way you can address that is simple by following the path that people go through from one service to another. Ensure that it's done comfortable with good results. That is the challenge to respond to multimorbidity. Now for that you need a tool. This is an individual personal healthcare plan. This is the Portuguese version, but there are other versions across Europe. And without this tool, you cannot manage the pathway across service of each individual with multimorbidity. Now, therefore, what we need is a tool that follows the patient as he goes from one service to another one, so we can have a plan that everybody participates on. Now, of course, we are starting this everywhere in Europe. For example, in England, the last report based on patient data is only 3% of persons with multimorbidity have a personal healthcare plan. So we are starting, but that's absolutely necessary to happen. Now, it's not only having a tool, of course. It's not only having a plan. You need to set it up. You need that everybody that collaborates with that plan has an agreement to collaborate in his own language. And finally, you need to evaluate the outcomes of the plan. And that's actually the best outcome evaluation you can imagine you can have in the health system. Now, this is happening everywhere. This is the good news. It's happening everywhere, slowly. Quick examples. The NICE in England issued the first clinical guideline for multimorbidity September 2016. This is a project of the European Union that agrees that the main tools for checking multimorbidity are the ones indicated in that slide. But of course, everywhere. In England, you have what they call the integrated care systems, experimentally trying to use the new tools to manage multimorbidity with good outcomes. This is the Finnish proposal. I'll go quickly. I will not read the slide, just show it in a glimpse and go over, because I need to tell you the entire story, not to be bogged into details. This is the Holland example. I will give you 3 seconds to read it, and I'll go to the next one. And even in France, now a month ago, President Macron and Agnès Buzyn, the Minister of Health, unveiled their healthcare reform plan, which also is based on the ability to manage the pathway of people that go from one service to another one. This is, again, the challenge. And as you will expect, this is our project in Portugal, that I can tell a bit more if you have some curiosity on it at the end. And of course, the European Observatory, WHO, even The Economist sets a meeting in February to discuss integrated care, patient-centered integrated care. Now, we can describe this. These are some of the descriptors. We can describe this quite neatly and easily. What's happening, what's not happening in relation to that. Now, you can agree that I can use this descriptors to describe the current situation, right? I can agree with you what's the desirable direction of change, and I can even try to anticipate the next stage. And I can share that with every stakeholder so we can ensure that there's convergence in action, okay? Now, this is great, this is a big challenge, but it's not enough. Since I place enormous burden in the system, in patients, in doctors, in managers, I have to couple this with a strong investment in health literacy. And health literacy is not only for patients. The old health education from a certain age group on an issue is old business. Now we talk about multiliteracy, which is literacy for everybody, patients, doctors, nurses, managers, and policymakers, through different channels with interrelated themes that give a sense of the system. Now, let me show you the library for health literacy was set up in Lisbon. This library is based on microsites in the form of digital books. Those are examples. And these books, macrosites, can be used coupled with a diary, so you can develop your own health diary and use that diary to extract information from the sites, so to build your own story about past health, present health, and future health. Now, this is part of overall health promotion, health literacy strategy that I'll not go again into details. I have to tell you the whole story. And again, as before, I can describe where we are in our health literacy strategy. Now, I can agree with you what's the direction of change that we should follow, and I can even try to anticipate what the next stage will be, okay? And again, I need to share this with all stakeholders so we can converge into productive action, okay? Now, I will argue now that if we do that, if we invest in responding to multiliteracy, if you invest in responding to multimorbidity, you create a climate to pressure for organizational change. Now, what's on organizational change? I'm using Mintzberg matrix to describe this. I will not go into details, but it works like this. We have a simplified organization that's command and control, the one that we know. We need to move for complexity organizations, adaptive systems, and avoid chaos, of course. And this can be done. Sorry to not stop into details, but I need to tell you the story. This goes this way. I'm not going to read it. I'm going to show you quickly what are the paths. Now, there are two underlying ideas about this transformation that I want to share it quickly with you. The first one is that transforming systems is basically transforming relationships within people. So unless we are able to transform the way people relate to each other, we don't transform organizations. It's something that we not always understand. We do it in paper, do it in laws, but not with people. The second thought, which I find very important, is that in complex systems, we don't give people simple solutions that don't work. In complex systems, we explain to people how the world works. Okay? This is a significant difference because we deal with complexity where elements interact with each other intensively. Now, again, I can take this organizational change, I can describe using Mintzberg matrix what the current situation is, what is the direction of change that we desire to follow, and what can be the next step. Now we can agree maybe also that we pushing not only for organizational change, we also are trying to enact policy changes, especially regarding the mobilization and use of resources for health. And this is a basic element of policy, and again, I will use Stacy's proposal here to describe these policies with two dimensions, one that goes from agreement to far from agreement to close to agreement on one hand, and on the end to close to certainty to far from certainty. And this will allow me to explain where we are in the process of advancing with policies that are affecting dealing with resource mobilization and use. Again, I will not go in detail. We can do that tomorrow or the day after. But I have to follow the story. And again, I will argue here that we can describe the policy situation using this matrix now, what the desirable direction is, and also, again, what the next stage could be. And again, as before, share this information with stakeholders so we converge in action. Now, we all agree that's very nice, but we have underlying context, not only social, political, and economic, but also cultural. So we need to put into our equation the cultural elements of change. And here, using Engelhardt's map, the most known cultural map that compares countries with each other. And here we have two dimensions, values that go from survival values to self-expression values, or values that go from traditional ones to secular rational ones. And we can map countries, Engelhardt did that, in this way. So Portugal is there in the middle of the two transitions. Greece is nearby here. I didn't represent it here. And again, if I represent where we are here, I have a description, and I can describe the current situation, direction of change. I can anticipate the next stage, and I can share this with everybody again. Okay, I will skip this one. Now, we have expressed here the view that this has a lot to do with how people relate to each other, how they cooperate or miscooperations. Now, data that we have show that some of us don't trust others. This is OECD data that shows that Portuguese and Greek people, only 20% trust others. Quite low. If you go to Ireland, it's almost double that value. If you go to Denmark, it's 73%. So in a way, if you don't trust each other enough, it's difficult to collaborate. If you don't collaborate, you cannot force this sort of transition. Now, if you look at data about social capital index, which puts together trust and ability to take initiatives for change, then again, I'm not going to read it for you, but the situation is the same. We have Nordic countries high indexed, Ireland in the middle, and our countries at the end of the queue. This gives a clear indication that if we want to foster transformation, we need to do what we call cooperative architectures. Unless we invest in cooperative architectures, it's quite difficult to go with those transformations. I have a list of them. I'm not going to talk about all of them. I select 3 or 4 to give an example. The first one is our Julian Tudor Hart. Probably some of you remember him. He passed away in July with 90-something years of age. He wrote 30 years ago an incredible book called A New Kind of Doctor that talks about co-creation of health, how you work with patients to create health. Now, it was not a theoretical book. It's a book about his 30 years of experience in the field doing that. Now, we are 30 years after he published the book, and after he passed away, we still didn't manage to have the new kind of doctor that we need. But we continue to work in that direction. Now, you will agree with me that most of our organizations and most of our professions have a strong identity core, but a very weak peripheral interface for collaboration. And we need to evolve in this direction. Unless we invest as much in our interface for collaboration as we invest in our internal core, it's difficult to come together and do the sort of transformation we need to. We invest in our internal organization, but not invest in the quality and professional type of our interface with other organizations. Mark Danson, you probably know him. He was director of WHO Europe. He visited us 2 weeks ago, and the last thing he did, he went to Toulouse and have a course as a mediator. Now, we now understand that we need mediators between organizations in order to foster change. We need mediators for departments that conflict with each other as we do change. We need mediators between digital tools and people, so we can better transfer. And mediation becomes a major profession in the health system now if you want to promote change. And finally, we need to construct this idea of collaborative intelligence, which is, as I was saying before, the ability to select information that follows trends of change that can be shared to promote convergence in change. Now, we have to pull all those things together, right? If we argue the complexities about interaction, we cannot see these transformations alone each other, okay? From each other, okay? Now, again, we can describe this jointly. We can agree on the vector of change, but we cannot predict the next change independently of each other. So when you come to predict the next change, we need to study interaction between them. There are two ways of doing that. The first way of doing that is based on informed assumptions, the ones I used during this presentation. I was using an assumption how things relate to each other, which is informed assumption and works like this. If I represent the different dimensions of the health system this way, and if I argue that we foster change by investing in multi-morbidity, integration, and health literacy to start with, then what will happen is something like this. And by doing this, I'll pull the other dimensions out also. So this describes a simple idea of interaction that comes for this informed assumption. But most of you will agree that it's too simple to reflect the real world, and we need to go further and find algorithms solutions close to artificial intelligence to be able actually empirically to study interactions, which means this is the general scheme that we now try to follow to go to a more complex way of looking at interactions. And that's what we need to do now empirically. And of course, I can summarize these ideas that I quickly survey for you in 3 different ways. The first one is graphic. I can describe, present, and discuss with you the main dimensions of the health system. I can argue that we can describe it in a certain way and anticipate the next stage. In order to have change, we need to invest strongly in these cooperative architectures, and part of that cooperation is collaborative intelligence. So that's one way of summarizing. Another way of summarizing is the main points of an essay written by Nick Black recently. It was published in July, that has 3 main ideas. The first, that we must be able to adapt to complexity, uncertainty, and nonlinearity. The idea that you can reform part of the system disregarding the rest is a naive idea, doesn't work in current days. Second idea, that those are human systems who have to focus on the relationship between its parts. We cannot do a primary care reform, a hospital reform, a long-term care reform, public care reform separately. It doesn't work. We need to see it jointly and understand them jointly and influence them jointly. And finally, unless you build on, you train, you promote what we can call social entrepreneurs, public entrepreneurs, then you have no leadership for this kind of change. And we don't know them. I know in Greece many social entrepreneurs. We don't usually give them the social value that they deserve. And there is a third way to summarize these ideas. And this, I will say it in Greek. So you can rate my Greek from 0 to 20. Λοιπόν, όταν τελειώσουμε από εδώ, θα βγω και θα πάρω ένα ταξί. Και θα με ρωτήσει στο ταξί, από πού έρχεσαι? Και θα του πω, από το συνέδριο υγείας, εκεί στο Καραβέλ. Και μου λέει, α, ωραία, υγεία, συνέδριο. Και τι είπανε? Λοιπόν, μπορώ να του πω, είπανε να μην προσπαθήσω να σας εξηγήσω Γιατί εσύ δεν καταλαβαίνεις. Δεν είναι πολύ καλή ιδέα. Or, I can tell him that we're talking about how you can improve your health, but knowing things that you don't know yet. And you can have even a personal diary when you collect that information and work through what you need to know. And if you have many conditions that force you, long-term conditions that force you to go frequently to the doctor, then you need a personal care plan. And you should have that plan, because that's important to have a quality follow-up of your disease. Now, if you manage that, many things will change your health system too. So, we can support you doing that, but you have to help too. And you can become a member of the Collaborative Intelligence Network of the Hacking Health here in Greece. And if you have any doubts, you ask Aris and Christos. Thank you very much.